Good evening to everyone present today. Well, more of the aspirants will be joining us soon. So, the topic for today is obstetric emergencies, and the speaker that we have here is Dr. Neeraj Kumar, who is Associate Professor, Anesthesiology and Critical Care AIMS, Patna. Thank you, sir, for being with us. You can start your class. Thank you.
Thank you, Fatima, for kind introduction, and I will be welcoming all our EDIC participants. Just I will request all those participants to keep your mic in mute mode, and thus today's class will be really a very interesting and important one. Why? Because this is one of the very infrequent topic that is going to be asked in many of the EDIC 1 exam. And Meanwhile, what I have done that I have tried to cover many of the topics related to obstetric emergencies, following which that I will be discussing what will be the physiological changes of the pregnancy, and then few important obstetric emergencies like acute embolism, amniotic fluid embolism, then your peripartum hemorrhage, preeclampsia, eclampsia, severe eclampsia. And meanwhile, what I've done that I have given few of the questions, that is type A as well as type K questions. So I will request all those candidates who are attending today's class, they can write the answers on the chat box only. Either the answers would be in the form of TT, like true statement, false statement, like that, or any of the options that you feel is correct. If the option is only one option is correct, like if the type A is there, so you can answer based on that only. And meanwhile, I will also request again that don't try to unmute your mic in between, because it entirely disturbs the class, and it breaks the uh, momentum as well. So I will not wasting much time. I'll just share my screen. Just wait. So the first important thing is that why these obstetric emergencies? Why? Because we know that these pregnant patients and the patients who are postpartum women, they always requires ICU admissions if they have pregnancies that is complicated, right? And it constitutes only 1% of the patients. If you'll see this data, only 1% of the pregnancies, and even less than 1% of these patients needs a ICU admission. So you can think that it is very rare, but it is very, very important, and it is very, very crucial. It is very, very critical to manage those patients. And they are primarily admitted not for the gynecological conditions, but they are primarily admitted for obstetric conditions. And most of these women are mostly, they develop some complications postpartum, with few exceptions like trauma and cardiomyopathy. They may occur in the prepartum period as well. Okay. Now, coming to the one study, they have suggested that sequential organ failure assessment score, like SOFA score, is one of the better, is not a better, it's one of the better system for predicting mortality in obstetric patients. So if we'll get a simple question that which one of the following scoring system is useful in predicting the mortality of obstetric patients, and if the SOFA is one of the options is there, so you may tick SOFA as one of the correct answer. And then these actual mortality rates are dependent on the disorder that can cause that ICU admissions. So let's see. So how? So they have done one study that was published in Hong Kong Medicine Journal in 2010, where they found that 50 obstetric patients were admitted to the ICU in Nether Seoul Eastern Hospital, and they collected this data from January 1998 to December 2007. What they found that out of these 50 obstetric patients, 0.65% of the total ICU admissions were, means out of 7692, 50 patients were having obstetric patients that required ICU admissions. And you see, out of these, 0.13% of all deliveries. So most of the patients, those who have admitted, they underwent that deliveries. Now, coming to the causes, if you'll see that cause, what will be the most common obstetric causes for that ICU admission in that 50 number of patients? So you'll see that first, the postpartum hemorrhage is topping the list. So this PPH is still one of the most common forms of admissions for the ICU. And then after that, pregnancy-induced hypertension, in which eclampsia, severe preeclampsia, as well as HELLP syndrome, which also uh, encountered in those complications, whereas amniotic fluid embolism, ruptured ectopic pregnancy, peripartum cardiomyopathy, and few less than 1% of these, one or two cases were from retained placenta or from septic abortion. So still, PPH is one of the most common cause or frequent cause of ICU admission. A few of the non-obstetric causes were also there, out of which the sepsis was following UTI infections, and then some respiratory tract infections as well. Few of the patients were admitted because of the chronic rheumatic disease as well, and few of the viral infections in the form of encephalitis or meningitis. Now, coming to the pregnancy adaptation, again, this is very important and futile topic for the questions that is going to get asked in frequently. They used to ask from pregnancy adaptations as well. Why? Because many physiological changes occurs during the pregnancy to adapt to the requirement of the fetus and placenta. That we all know. To maintain that equilibrium, the fetus between fetus and placenta, these physiological or these adaptations usually happens, and these happens in almost all organ, not a single organ system that is going to be not going to get adapted following this pregnancy. While the important roles in changes in the hemodynamic monitoring and ventilation, that's why these two things are very important for hemodynamic monitoring, as well as for ventilating these groups of patients. And now you see that why it is there, because of the progesterone, because this progesterone is responsible for most of these adaptations, and because it is one of the potent smooth muscle relaxant as well as respiratory stimulant. That's why hemodynamic monitoring, because of the smooth muscle relaxant effect, as well as respiratory stimulant, so it impairs the ventilation as well. And what happens most of the time after delivery, about 6 weeks it takes for the maternal physiology to returns to the normal. So again, it may be asked that what is the normal physiological adaptation at which the maternal physiology returns to the normal. So it may be one of the fact-based questions that may be asked in your exam. Now, coming to the next part, that out of which adaptation most frequent, yeah, most dramatic is the cardiovascular system. So cardiovascular system is again most important physiological changes, which is important for all of us. Now, what happens exactly in these patients, that the blood volume, first of all, the blood volume increases up to 50% in singleton pregnancy, which compensate. Why it increases? Because there is blood loss which happens during the delivery. So to maintain that or to compensate that, the progressive increase in blood volume is there. And then out of which these placental vasculature, it receives almost out of it almost receive 30% of the cardiac output. So almost 600 ml per minute at term, the placental vasculature receives the blood from, because of the cardiac output or a heart contractility of the heart. And about 1/6, like 16% of the maternal blood volume is located mainly in the uterus at any time. So anytime you can have a 16% of the total maternal blood volume. And now these blood pressure declines during the first trimester to nadir value. Typically, if you'll see that systolic varies from 85 millimeter of mercury to 110 millimeter of mercury systolic, and diastolic varies between 50 to 70 millimeter of mercury in the second trimester. And these blood pressure again returns to normal or pre-pregnancy value in the closer or at the end of the third trimester. Now coming to the again here important is, following these cardiovascular system, these cardiac output first, they increases by 40 to 50% by 10 weeks due to because this is the time where there is sudden increase in the stroke volume and a smaller increase in the heart rate. So heart rate will not increase much, but a stroke volume will increase very much. We will try to discuss later how these stroke volume affects your left ventricular in diastolic pressure, and how at a particular time, if the stroke volume if then what happens happens at a particular time, the stroke volume doesn't increase enough, and but after adding inotropes, the patient can be prevented on going into a cardiac failure or congestive cardiac failure. So this we will read in a Frank Starling law in later part of this discussion. Now coming to there is always a marked reduction in the TPR. Why? So total peripheral resistance is going to get decreased. So what will happen? There is a systemic vasodilatation that will appear, and these systemic vasodilatation will decrease the blood pressure. Which blood pressure will be more decreased? It is diastolic, which is affected more than systolic. And then again, it returns to the pre-pregnancy level by third trimester. And the second, we were very much aware about supine hypotension syndrome because of the aortocaval compression, which what it basically do, it decreases the preload and it increases the afterload. So that has to be kept remembered in your mind, that how these aortocaval compression is very, very dangerous for these pregnant patients, because many of the time the preload is going to get decreased and the afterload is going to increase. Okay. Now coming to the next important part is that if these patients have a significant maternal hypotension because of that systemic vasodilatation, then what happens? These placenta act separately from the vital organs, and then it start experiencing vasoconstriction. Okay, so if because of the significant maternal hypotension, now these placenta will come into action and it will poses a vasoconstriction effect. Why? This leads to hypoperfusion of the placenta. Okay, with resultant. So if these vasoconstriction at the placenta level will be there, so what does it net result will be there? So fetal hypoxia. Net result will be fetal hypoxia as well as acidosis. Now, so now these two will be very, very detrimental. So that has to be corrected very, very quickly. If placental vasoconstriction will be there, or uteroplacental insufficiency or uteroplacental vasoconstriction will be there, so it can directly result in fetal hypoxia and acidosis, which is following a maternal hypotension. So if you are not going to manage these hypotension very, very frequently, your patient is going to your child or your fetus is going to be impaired. Now here what will happen? You will see that the patient will, or the fetus will, have a variable fetal heart rate, or sometimes these patients may present with bradycardia on a monitor, which is a first sign of maternal status decline. So this may be asked one of the question, that what would be the first sign of maternal status decline? So the answer would be decrease in the variability of the fetal heart rate. If this option is not given, then bradycardia could be another answer, but decrease in the fetal variability is the best answer. How it is been done? Because of the maternal hypotension. So this may be one of the question that may be asked. Now the mother can lose up to how much volume? Up to 30% of her volume before her vital signs changes. So you see that how this compensation is going on there. But still, if you're not going to predict, if you're not going to manage these patients, so if mother has already loosened up to 30% of his blood volume before you notice any change in her vital signs. Okay. Now coming to the next part. The next part from cardiovascular is hematological, where we can very easily understand that this pregnancy is hypercoagulable state, and here the plasma volume is always going to get increased, and then in comparison with red cell volume, there may be dilutional reduction in hemoglobin concentration as well. These patients may have neutrophilia, and they may have 10 to 15% reduction in the platelet count. So these patients may have some forms of thrombocytopenia as well. Okay. Now coming to the respiratory part. So what happens in the respiratory? Because we already read that this progesterone is a respiratory stimulant. So what happens? Many of the time, this increases the respiratory rate. Okay, first. So on increase in the respiratory rate, there is also increase in the tidal volume, and simultaneously the oxygen consumption will also increase. So if the tidal volume is increased, if the respiratory rate is increased, so the overall the minute ventilation is also, or minute volume is also going to get increased. But because of the increase abdomen or increase abdominal size, the residual volume as well as functional residual capacity is going to decrease in these patients. And these patients, again, one of the questions that may be frequently asked as a one-liner, that the pregnant women have a normal respiratory alkalosis. They may give you a small ABG findings, and they can ask that what these pregnant patients normally have. So they have respiratory alkalosis, but how these respiratory alkalosis is going to get compensated with metabolic acidosis. So overall, this this is the question, that respiratory alkalosis following a compensatory metabolic acidosis. Many of the time, these pregnant patients normally have. Now, what basically it does, it increases the removal of fetal PCO2 as well as acidic metabolites. And now the diaphragmatic mobilities later on in the pregnancy is also going to get compromised. That's why in later stage, the FRC is further going to get reduced. Now coming to the next part is what happens exactly over the renal part. So renal part, there is increase in the GFR, there is decrease in the urea concentration, decrease in the creatinine concentration as well. There is mild reduction in the sodium level. So mild hyponatremia maybe is there because of the mineralocorticoid effect, and that's why these patients have net gain in fluid balance. So net gain cumulative fluid balance will be more because of the mineralocorticoid effect, and these patients have from the normal value lesser amount of sodium will be there, which is responsible for increase in weight gain. Now coming to the GI part, so GI part, straight away these patients have increased risk for constipation as well as GERD, and they have increase in alkaline phosphatase level, and then transaminitis will be not there, whereas SGPLT and SGOT values will decrease and albumin values will also decrease. So if now here again a question is there, if maternal oxygen partial pressure falls below 47 millimeter of mercury, the umbilical vein concentration begins to decline. So this is the cutoff value where the umbilical vein concentration begins to decline. Okay. So now again the next part is now this is again a very important question, that what is the vasopressure that has to be added in a pregnant patient for treating these maternal hypertension if it has happened following subarachnoid block. Okay, so many of these patients have a maternal hypertension following subarachnoid block. So what happens? So vasoconstriction will be occurring in all vessels during pregnancy, and it is important to select an agent because you have to select a inotropes or a vasopressor which preserves the uterine blood flow as much as possible. So our goal is to preserve the UBF values as much as possible. So what you are going to do? So I will be going to do where the uterine vessels, these uterine vessels are maximally dilated. Why they are maximally dilated? Because they have only alpha receptors in their, they are having much density of alpha receptors. That's why these uterine vessels are maximally dilated. So what happens? So you have to use the drugs which have more effect or more better effect over preserving this uterine blood flow. That's why they play a role in determining the sensitivity to sympathomimetic agents as well. Now you see there are four choice of drugs, which could be ephedrine, first choice, which could be phenylephrine, second one, and then dopamine, and then vasopressin. Now you just see one by one that how this is different from others. So if you want to use ephedrine in these patients for treating maternal hypotension, so it is going to get preferred. First point, it has got good safety record. Second best point, that is positive for this drug. This has a minimal effect on placental at low doses. Now this is one of the problem, that if you are using a lower dose, so the effect on the placenta is very less. And what you want to do, you want to maintain the uterine blood flow or placental blood flow in a better way. So here one of the drawback. Second, it crosses the placenta. So again another drawback of using ephedrine, that it crosses the placenta, and they have reported that they can cause fetal tachycardia and acidosis. So if the patient is, if you have not treated that maternal hypotension quickly and you have delayed a time and then you have added ephedrine, so what has happened? Because of that hypotension, the mother have already more increase in fetal hypoxia as well as acidosis. And if you'll further add ephedrine to these groups of patients, so because of the fetal tachycardia, the fetal tachycardia, the fetal acidosis will further increase. That's why it will be compromising the fetus as well. Now again, important aspect is that if you are using ephedrine, bolus is always better for short-lived hypertension. So if a very short span hypertension is there, you can use bolus ephedrine for treating those hypertension. Now you come to the if phenylephrine point. So it causes more uteroplacental vasoconstriction. First, negative point. Now, second, not more fetal acidosis as compared to ephedrine. That's why adverse neonatal outcome is not there as much that what ephedrine can cause. First point. So it is one. It is the added advantage of using phenylephrine that it doesn't have that effect on fetal acidosis as well as tachycardia. Now, again, important point is phenylephrine can be used as an infusion agent if you need, if you think that the duration, longer duration is required for treating those maternal hypertension. Now, this is again an important aspect that has to bear it. That's why many of the questions, the choice would be always phenylephrine, but you must read the question very carefully. But that what they are asking. If they are asking at the at uteroplacental vasoconstriction, so uteroplacental vasoconstriction occurs very less at lower dose of ephedrine, but at optimal dose of phenylephrine, the more uteroplacental vasoconstriction will be there, but fetal acidosis is not as much as ephedrine. Now coming to the dopamine, so it has been studied in few of the patients who are pregnant with sepsis. So overall effect, uterine blood flow, they have not elicited. And dobutamine here, they are talking that dobutamine may be a better choice inotropes because it consistently increase the pulse rate, but it doesn't affect the map. So it doesn't affect the map if you talk about the dobutamine or dopamine. But here specifically, there is no such study which has seen that overall effect on the uterine blood flow. But what they have found, if you are using dobutamine in place of that, so map is not going to get disturbed, but pulse rate is going to increase on dopamine. So overall, they have not used these drugs for treating maternal hypertension. Now coming to the vasopressin, if you want to use intravenous vasopressin or intramuscular vasopressin, so both can cause uterine contractions, and they again it is not required in treating maternal hypertension. So the first choice would be if phenylephrine, and second choice would be ephedrine. But you have to look for these questions very carefully.